So today this lecture is about women in epilepsy. So I've decided just to focus on perspectives and management. It'll be like a whirlwind tour, because each of the subtopics could be a lecture on their own. So to think about women, famous women with epilepsy, there's Harriet Tubman. She famously had post-traumatic epilepsy from like a horseshoe striking her head, and she had seizures in the field. It did not stop her from running an underground railroad and bringing people to their freedom. So that's good to know. And then a fictional character from Garden State who had her epilepsy helmet, which is not something we actually do in real life. So why is this topic important? Women are half of all patients with epilepsy. In the US, there are 1.1 million women with epilepsy who are of childbearing age. And in our country, more than half of all pregnancies are unplanned. So it comes out to about 24,000 babies being born in the US to mothers with epilepsy each year. So special considerations for women with epilepsy are contraception, fertility, pregnancy, birth outcomes, and breastfeeding. So we'll go through each of these topics. Regarding contraception and anti-seizure medications. So this falls into two subcategories. You can have contraceptive failure due to your seizure medications, or a failure of seizure control due to your contraceptives. So this is a very pretty diagram of cytochrome P450 3,4A. It's a monooxygenase and it's found in the liver more so than intestines. This is the enzyme that metabolizes about 30% of all your prescription meds. This enzyme is induced. That means its levels are increased by some of your seizure medications. And it's a key to understanding the effects of contraception, since this also metabolizes progestins and estrogens. So your medications, some of your seizure medications will either induce this or inhibit this, but this enzyme also metabolizes your estrogens and your progesterones. So estrogens and progestins are your CYP3A4 substrates. And so when you induce this enzyme, you lower your estrogen and you lower your progestins, and you potentially have lower effect of your combined birth control or your contraceptives. So all the medications that cause CYP3A4 induction can lead to higher risk of contraceptive failure with your hormonal contraceptives, with your estrogen progestins. So that your enzyme inducers are carbamazepine, oxcarbazepine, lesofenadate, dilantin is a strong inducer, phenobarbital is a strong inducer, primidone, topamax, and also perampanel. So randomized controlled trials with also designed found higher ovulation rates with carbamazepine in women taking combined oral contraceptives. So this is not looking at rates of breakthrough pregnancy despite OCPs, but the OCPs are supposed to inhibit ovulation. So if women are ovulating despite taking the contraceptives, that means that could lead to failure and unintended pregnancy. So not all the enzymes are equal levels of affect the medications at the same level, because their effect on enzyme induction is different. So some of your strongest medications, your strongest enzyme inducers like phenobarbital, dilantin, and carbamazepine would be the most likely to cause your contraceptive failures, compared to like oxcarb, which I think has lower enzyme induction properties. So then, then you think, how can I find, a medication that would not affect my OCP? So there are birth control methods with no interaction. That means there's no hormones being metabolized by CYP3A4. And so these are mechanical barriers like condoms, diaphragm, spermicide. Then there's your IUDs, which don't prevent ovulation, but prevent implantation. And then your medroxyprogesterone depot injections. Alternatively, you can stick with your hormonal birth control, but choose a seizure medication that does not does not induce your CYP3A4. So that would be your levetiracetam, your zonisamide, your ethosuximide, your benzos such as Onfi, clobazam, gabapentin, and tiazine. theoretically, valproic acid also does not interact with your contraceptives, but it's a bad idea for other reasons. So I've crossed that out for you preemptively. So we talked about birth control failure due to your anti-seizure medications. The other side of that coin is you can have seizure control, failure of seizure control due to your anti-contraceptives. So that means because you're taking birth control pill, your anti-seizure medications don't work as much and you have breakthrough seizures. And so this is the enzyme that's involved. This is uridine diphosphate gluconol transferase, UGT. This enzyme's activity is induced by estrogen, estradiol. It's involved in glucuronidation, which is how lamotrigine is cleared from the body. So lamotrigine is cleared from the body by this enzyme that glucuronidates it. So it also plays a minor role in Depakote and acetylcarbazepine metabolism. So, for example, if someone takes an OCP, their Depakote levels may fall by 20 to 40%. But the main consideration is lamotrigine. So with Lamictal and combined oral contraceptives, your levels may drop as much as 50% with the addition of estrogen-containing contraceptives due to this increase in glucuronidation. So if someone's starting on an estrogen-containing birth control, you want to check their baseline level, and then before they start, to know what level they had in which they had good seizure control. And then you want to kind of check, maybe up titrate a little bit to start if they're mid-therapeutic, and then check later and see how much you have to add to get them back to that same level that they were on at baseline. So we always check to start, but also when people stop their contraceptives, because this glucuronidation is no longer induced, you may have toxic levels of Lamictal. So that can also be dangerous. So that should also be planned. This gets complicated because lamotrigine also induces a clearance of progestins through another pathway. So if you take estrogen with lamotrigine, your lamotrigine will not work as well. You'll get a lower level. But if you take progesterone with lamotrigine, the progesterone may not work as well because it's cleared by the enzymes that are induced by Lamictal. So this has to be very carefully considered. A lot of my patients on lamotrigine are on IUD, which acts locally. But it's definitely something that patients need to be aware of, that when they start or stop contraception, in addition to talking to their OB, they should talk to you. So part 2, we talked about contraception. So next is fertility. This is an overview by Dr. Jackie French about fertility and birth outcomes in women in epilepsy seeking pregnancy. So this is just a big cohort of patients who have epilepsy and who wanted to be pregnant. So there were 89 women with epilepsy and 108 controls. Their mean age was 31. I think this is an NYU cohort. 31, that's an age in which, the average. So they looked at what percent of the women were able to achieve pregnancy. So 60.5% in the epilepsy group versus 60.2% achieved pregnancy by 1 year. So the median time to pregnancy was 6 months in the epilepsy group and 9 months in the control group. The p-value is 0.3. So that means there's no difference between women with epilepsy in New York City trying to become pregnant versus women without epilepsy. The ranges are about the same. They had them track sexual activity and ovulation rates, and those were similar. So here they said women with epilepsy seeking pregnancy without prior knowledge of infertility or related disorders have a similar likelihood of achieving pregnancy and time to pregnancy and live birth rates. This is an observational cohort. Most women in this epilepsy group were taking either Keppra or Lamictal, which is medications of choice for women of childbearing age, especially those who are looking to become pregnant, because these are considered the safest 2 medications in pregnancy. If you looked at other cohorts, other women may be on very different, you have different populations, you have different rates of infertility. So in this, this is a registry coming out of Kerala. And they found that polytherapy increases the risk of infertility in women with epilepsy. They followed 375 women for 1 to 10 years. 231 had pregnancy and 144 remained infertile. They actually found that the infertility rates kind of went up as the number of medications went up. So some women with epilepsy without AEDs, the rate was actually very low. At 1 AED is 31%. That's kind of tracking the Dr. French's New York City group. At 2 AEDs, it went up higher, and the rate of infertility was actually pretty high with 3 or more anti-seizure medications. So the predictors of infertility were older age, which is also always a predictor of infertility. Being on 3 or more anti-seizure medications increase your odds of infertility by a factor of 17. And for unclear reasons, a lower education level was also associated with infertility. What they found was that phenobarbital, out of all the medications, had a significant association with infertility. This paper didn't break down what medications patients were on, but because it's a low resource country, a lot more patients were on phenobarbital there compared to New York City. With regards to pregnancy, there are study groups that look at pregnancy. In the US, we have the MONAD. Here, this is the EURAP, it's a European study group. They found that 60% of women with epilepsy have similar seizure control during pregnancy, 15% have more seizures, and 15% have less. So before going in, some women actually have better seizure control, most stay the same. A big predictor for whether women will be seizure-free during pregnancy is if they're seizure-free for the year before pregnancy. So if they've been seizure-free for more than 1 year, there's an 80% chance that they'll remain seizure-free. However, their risk of status epilepticus is higher, so it's 1.6, but this was actually not found to be significantly different from their baseline risk, but I need to double check that. So there's a study looked at SUDEP and epilepsy-related mortality in pregnancy in 2014. The rate of maternal mortality was actually much higher in women with epilepsy compared to, and most of that risk was from SUDEP. So SUDEP stands for sudden unexpected death in epilepsy. Overall, this kind of suggests that pregnancy is a higher risk time for women with epilepsy. There's a lot of changes going on. This study actually found that half of all deaths occurred in women on lamotrigine monotherapy, which is very interesting because Lamictal is one of the preferred medications in epilepsy and pregnancy. I think this is probably related to the increase in clearance, because during pregnancy, your estrogen levels go way up, and unless you chase it, the Lamictal levels tend to fall. So this study found that the risk of having breakthrough seizures in Lamictal monotherapy occurred when your serum levels of lamotrigine fell more than 30% from your baseline. This is a chart of anti-seizure medications in pregnancy and FDA drug categories, right? So here, this is how we kind of formed this is how medications were all classified prior to 2015. So I think all our medications, most of them are category C. They were not studied in pregnancy. Several of them are category D, and then your Depakote is category X. So for new medications, there are new sections, and so after 2016, the medications that came out after that are not categorized by A, B, C, D, X. They talk about, there's a insert in the package insert. They talk about the risk summary, clinical considerations. They talk about animal studies. So one of the medications that is not categorized like this is Vimpat, your lacosamide. You just kind of get a packet insert about what they know about pregnancy and lacosamide. So in regards to your seizure medications in pregnancy, none of your medications are, well controlled, shown to be safe, right? None of them are category A and B. Most of your medications are category C and D. Valproic acid was moved from category D in 2013 to category X, but this indication is valproic acid for migraine prevention is category X. So it can still be considered in dire extreme circumstances for epilepsy in pregnancy. That means you categorically cannot use Depakote for migraine prophylaxis or for migraine treatment. But for epilepsy, it can still be considered and hopefully very well documented. So these are the medications that are category C: acetazolamide, Onfi, dosuxamide, felbamate, gabapentin, lamictal, levetiracetam, oxcarbazepine, tiagabine, vigabatrin, zonisamide. These are category D: carbamazepine, clonazepam, phenobarbital, dilantin, topamax. So in practice, what I try to do is I try to avoid this category, and I try to have my patients on this category. Among this category, the best evidence for safety is in lamotrigine. That was in one of the original clinical trials that looked at dilantin, phenobarbital, lamictal. This one had the best birth outcomes. And now Keppra, so many of our patients on Keppra, I probably consider it safer and easier to manage in pregnancy. So most of my patients, if they can do well on this, are in Keppra monotherapy. If patients are on oxcarb, I'll maintain them on oxcarb. Back in the day, if patients have been doing well on carbamazepine, it was considered too high risk. Now, if patients have been doing well on it, it's a risk-benefit discussion. I may leave them on it, or I may try to switch them in an EMU setting to oxcarb. There has been, so lacosamide is not on this list because it's not pregnancy category, but there is an ongoing registry, and it seems like the signal is that there's been 200 pregnancies with lacosamide monotherapy, and there actually have not been any bad birth outcomes. So it seems like the signal is that it's safe. Onfi is on this list, but there's some evidence coming out of India that it may be associated with lower birth weight. So maybe eventually, I do try to avoid Onfi in pregnancy. So these three, I think, are my go-tos in pregnancy. What are the risks of anti-seizure medications for the fetus? So seizures during pregnancy can lead to maternal hypoxia, and then that can lead to fetal bradycardia, which is reversible. But there's an increased risk for preterm births in women with untreated epilepsy. The risk is higher with smoking. So all your pregnant women with epilepsy should definitely stop smoking. That's usually kind of good advice for pregnancy in general. Babies born to women with epilepsy are high risk of being small for gestational age, and then they have a smaller head circumference, which may be just associated with the small for age. There will always be a slide about Depakote in pregnancy. Guys, please don't discharge your women of childbearing age on Depakote in pregnancy. You're just like setting yourself up for problems. So it's associated with neural tube defects, such as spina bifida, hypospadias, brain malformations, anencephaly, and also limb defects. There's a 10% risk of major congenital malformations, which is dose-related. Now let's look carefully at these doses, right? If the dose is less than 700 mg daily dose, the risk is 5 to 6%. But if you think about the doses we use in clinical practice for a therapeutic serum level, I think the dose I use, like a low dose, would be like 500 twice a day. Many patients are on 750 twice a day, right? So if the patient is actually on 750 twice a day, they have a 24% or more chance of having a baby with a major congenital malformation. That's a 1 in 4 chance that their baby will have something structurally wrong. They found also that in utero exposure is associated with increased risk of autism. And also they've tracked babies who were born and appeared healthy structurally, but at age 6, they found that they had lower IQ than their peers. So in comparison, lamictal, carbamazepine, dilantin, they had expected cognitive outcomes at age 6, control for parental and socioeconomic factors. But they had lower IQ if they were on Depakote. So folic acid supplementation at more than 0.4 milligrams a day in breastfeeding actually improved cognitive outcomes in these babies who were exposed to Depakote. So this is near normalizing the breastfed group. So if a woman needs to be on Depakote because they've shown status epilepticus in the past whenever it was tried to be weaned off and they had to be on a low, what we would do is try to get them on the lowest dose possible, less than 700 milligrams daily, but definitely have them be on folic acid supplementation and also breastfeed. This study was done in one of the Scandinavian countries where they have very good records about prescriptions, and they were able to really track outcomes. So what are the risks of the other anti-seizure medications, right? The rate of major congenital malformations in babies born to moms with epilepsy is about 4%. This is a little bit higher than the general population risk, like it's 2 to 3% in all comers. So it's slightly higher in women with epilepsy. This is considered an AD class effect, right? So neurotube defects, cardiac malformations, cleft palate, these are considered malformations that can happen with any of the anti-seizure medications, but they are highest with Depakote. In the North American AD Pregnancy Registry, these are voluntary registries that women sign up for when they become pregnant. They found that phenobarbital had a 6% risk of major congenital malformations. Most of these were cardiac defects. And Topamax had a 4% risk of facial clefts, like cleft lip, cleft palate. In a Cochrane review, Lamictal and Keppra were associated with the lowest teratogenic effect, and that's the reason why they're the drugs of choice in pregnancy. And actually, in women of childbearing age with plans to become pregnant, may become pregnant. Let's talk about folic acid. Folic acid is vitamin B9. It's involved in purine synthesis, which is required for DNA formation. So deficiency leads to neurotube defects in the general population. That's why our cereals were fortified. It is involved in this reaction, dihydrofolate reductase to tetrahydrofolic acid. So the dihydrofolate reductase inhibitors, so if you inhibit this, you prevent this from becoming this, which is the active form. So those are dilantin, phenobarbital, and carbamazepine. The major risks of having a major congenital malformation with these three medications due to this effect is a factor of 3.4. Other hepatically metabolized seizure medications can also increase the risk of low folate by up to 90%. So that's why folate supplementation is very important. So the recommendations by the American Epilepsy Society is that all women with epilepsy should be encouraged to take at least 0.4 milligrams of folic acid daily. The AIM and the Epilepsy Foundation encourage all women to take folic acid, possibly at a higher dose of 4 milligrams. So in my fellowship training, we had all women on 4 milligrams of folic acid, like 3 or 4, especially if they were on the carbamazepine or some of the strong enzyme inducers that cleared the folic acid. However, there's been studies coming out of like the Scandinavian countries that high dose folic acid supplementation may increase the risk of asthma, unknown pathway, but they saw that association. So in practice, what I have done is I have all my women with epilepsy, especially all the ones who are not on Keppra, on 1 milligram of folic acid daily, just 1 milligram. And that's with the understanding that folic acid is important for kind of like general health and important in case they get pregnant accidentally, which is 50% of all pregnancies. What happens to the seizure medications during pregnancy? Okay, so during pregnancy, the volume distribution goes up, hormones fluctuate, and drug clearance may increase. So we talked about Lamictal and how estrogen increases glucuronidation with each of your Lamictal. Here, with your body makes a lot of extra estrogen during pregnancy that increases your UGT, which increases Lamictal clearance by up to 50%. So oxytocin levels also drop in pregnancy, but the most dramatic is with Lamictal. And a greater than 35% decrease in serum lamotrigine levels is associated with breakthrough seizures. So you're supposed to monitor all AD levels preconception and then every trimester. For oxcarb, they say check monthly. For Lamictal, may require serum checks weekly or bi-monthly. So basically, for my pregnant woman on Lamictal, I basically check their lamictal levels at every visit, which can be, I can see them like all the time, like every 3 weeks. The problem with lamictal levels is that it takes time to come back. So you're always chasing yourself a little bit to get them to a good level. Pregnancy and lamictal is a time when you will see your patients a lot. One of our wish lists as an epileptologist is like point of care lamotrigine testing. That would be supremely helpful. Some questions we have is, do you switch AD or discontinue during pregnancy? That's like there's no evidence for this, but this is my general practice. Usually I don't. The time to consider switching is before conception. It takes lamictal 2 to 3 months to get to a goal dose, even without pregnancy. So by the time the patient is pregnant and their estrogen is going up and it's chewing through the lamictal, it's too late. You'll never get them to a therapeutic level in a safe way during their pregnancy. I will seriously consider medication switch only for valproic acid. And a lot of individualized counseling is involved. So it depends on the trimester, it depends on how hard they've tried before, what dose of valproic acid they're on. If you have a poll of a patient who accidentally got pregnant on valproic acid, and you poll a room of epileptologists, the answer will really change. You'll get half your hands up for one thing, and it depends on the trimester. Would it be worth, neurotube defects happen in the first and second trimester. Would it be worth it, tapering them and switching them in the third trimester? So all of these, it's individualized, and these are tough situations that you try to not get yourself into before it happens. Time to get a woman off Depakote is before they become pregnant. So you can consider medication dose down titration, especially for Depakote, under an EMU setting, if the epilepsy was well controlled. And this is why I say you should not start any female of childbearing age on valproic acid, regardless of their plans for conception. I'll have women that I offer, a medication switch, and they say, no, I'm single. I'm fine, I'm doing well, I don't want to change anything. And the next visit, before I can even bring up, they're like, Dr. Wang, I'm pregnant. And that's something you never want to happen on Depakote. If you have any patients in your general neurology clinic that just happen to kind of age and to be on Depakote for whatever reason, just send them to me so I can do something about it before it becomes a problem and they become pregnant accidentally. And then it's all hard questions. Please do that right now. Just go through your mind and think about anyone you have and then send them right over. Because I'd rather do this now rather than kind of worry about it later. This causes me anxiety. 24% of a major congenital malformation is just too high. So during pregnancy, pregnant women with epilepsy are twice as likely to stop their anti-seizure medications as a group that is not pregnant. And a lot of them will just stop once they find out they're pregnant because they're afraid of the risk to the fetus. However, uncontrolled epilepsy is a major risk to both mother and the fetus. So I tell my patients early and often, if they discover they're pregnant, don't stop their ADs, schedule a follow-up with a provider or an epilepsy specialist. So a lot of women are managed by, they are seizure-free on a monotherapy. They can be managed by a general neurologist. In some rural areas, they're managed by an internist. But I think during pregnancy, it's a good time to have them see an epileptologist. This is really when, especially if they're on lamotrigine, but epilepsy and pregnancy, it's a time to send them to, epilepsy clinic. After birth, there are also considerations in the postpartum period. There's been a study looking at morbidity and mortality during delivery among pregnant women with epilepsy. So they found a higher risk of preeclampsia, preterm labor, C-section, and long hospital stays. And the mortality odds ratio is actually 11.4. That means they are 11 times higher of having in-hospital mortality compared to women without epilepsy. So seizures occurred during delivery in about 2% of women with epilepsy. This was higher when they're subtherapeutic anti-seizure medication levels. So you can prevent that by kind of just tracking your patients closely during pregnancy. Seizures during delivery are associated with prolonged contractions and slowing of the fetal heart rate. And this is actually very interesting data because I would assume that the slowing of the fetal heart rate occurs during all seizures, but it's during contractions. I mean, during delivery, that's when all of this is monitored. During delivery, you just kind of make sure that patients get their scheduled medications. If they're NPO for whatever reason, you give them an IV formulation of their seizure meds. So like for Keppra, replace the same dose with IV Keppra. Just know that a history of mood intolerance to Keppra is not a contraindication of using Keppra in the short term. So let's say that they were NPO because they were on a medication that had no IV formulation. Like let's say they were on like zonisamide, right? For 1 or 2 doses, they can be replaced with Keppra unless it's an allergy. And being irritable is not a contraindication to getting a couple of doses of Keppra while you're actively pushing a baby out. Like that's okay. They can get a 1-to-1. Lots of things are happening. It's okay for them to be a little bit irritable and not have a seizure. So if the patient had been doing well on a sodium channel blocker like carbamazepine and oxcarb, but they just can't take it orally, I've replaced those doses with lacosamide, which is a slow sodium channel blocker, and it's the only one besides dilantin that has an IV formulation. This is a common consult we get after delivery. A lot of women are reluctant to breastfeed. I always encourage it. So I encourage it while considering it, the individual drugs. So the benefits usually outweigh the risks. Protein-bound drugs have lower penetrance into the breast milk. So your Depakote, dilantin, carbamazepine are protein-bound. They do not penetrate into the breast milk. Most other anti-seizure medications also have low penetrance, and they've checked infant serum drug levels, and they have not found like therapeutic levels in the baby, and babies generally do well. The one exception is this. Phenobarbital and your benzos, like your clobazam, Valium, they have a very long half-life. And so even though excretion in breast milk is low, over time it can accumulate and cause drowsiness and poor feeding and poor weight gain. So in practice, what I do is if babies are on any medication besides phenobarb and benzodiazepine, I start counseling mothers to really consider breastfeeding for all the benefits, the IQ benefits, the immune regulation benefits, well before they're given that option, so that they're not considering it when all these things are happening, that they have a plan. They're like, I'm on my Keppra. My epileptologist told me that breastfeeding is safe and the risk is low and the overall benefit to my baby is high. Exceptions, clobazam, phenobarbital. Everything else, please recommend breastfeeding. If you look up each individual drug, they'll say there's no clinical trial to show that it's safe, which is kind of how all of these medications are in pregnancy. They will never do a clinical trial on pregnant women and breastfeeding women. That's just how science has worked out in pregnancy. So the benefits of breastfeeding is that there's this Norwegian cohort, and it showed that continuous breastfeeding for the first 6 months of life was associated with better fine motor, gross motor, and social skills, despite the mother being on anti-epileptic drugs. And at age 6, there's a cohort that looked at breastfeeding outcomes at age 6. They had 181 mothers on anti-seizure medication monotherapy. Half of the children were breastfed for 7.2 months. And at age 6, the breastfed children had higher IQ, and none of them had any bad side effects. So breastfed children actually had lower risk of developing epilepsy at age 1. Let me see, I think this, whoa, hold on. Oh, no, nope, sorry guys. Lower risk of epilepsy at age 1. And this showed a dose dependence. So breastfed children, babies who were breastfed for longer had a lower risk of developing epilepsy. They don't actually know the mechanism of action. They just saw it when they looked at big groups of babies who were breastfed whose moms had epilepsy. But I think it may be related to like just immune modulation, maybe lower risk of infection and fever, which could cause like kindling and like febrile seizures and then epilepsy. So please, the evidence is that breastfeeding is good, even if the mother is on anti-seizure medications. except if it's phenobarb, and except if it's a benzodiazepine. So in summary, pregnancy is a high-risk time for women with epilepsy. This is when you consider referring even your well-managed patients who are seizure-free to an epilepsy specialist. The time to consider anti-seizure medication change for pregnancy is before they are pregnant. If the patient has an unclear diagnosis of epilepsy, the time to clarify is before pregnancy. So if a woman is on 3 anti-seizure medications with suspected PNES, when she's pregnant is not the time to go to the EMU, lower her medications, and see if she seizes, because you could bring out real seizures and then she'll have all the risks associated with having seizure.